Is it coming? Let's check. Coming. Okay. Okay, friends. We come to another revision lecture of acute respiratory infections. Acute respiratory infections has gained a lot of importance because of the current pandemic. And if you really look at it, we from the community medicine side or from the public health side have been harping on this since ages. But as is usual, no one listens to the public health people. And if people had listened to us and had taken action for prevention of acute respiratory infections, this is exactly what we have been saying since ages, that please be careful. Acute respiratory infections are the cause of a large number of illnesses, and especially among the children, acute respiratory infections is one of the leading causes of morbidity and mortality. The second most important cause of morbidity and mortality in children, acute respiratory infections, and second one is gastroenteritis. So we have two very important infections which cause a lot of morbidity and mortality in children. Acute respiratory infection per se causes a lot of morbidity and loss of man days in the adult population also. Let's go through this, and I will be running through because this is a revision lecture. So let's see the epidemiology. Infections which cause inflammation of the respiratory system, which anywhere from the nose to the alveoli with a wide range of signs and symptoms is what we're going to talk about. So you can have right from sinusitis, common cold, pharyngitis, epiglottitis, laryngotracheitis, bronchitis, bronchiolitis, or pneumonia. So ARI is responsible for 3.9 million deaths every year. 6.8% of the worldwide deaths is because of acute respiratory infection. Bangladesh, India, Indonesia, and Nepal together constitute about 40% of global mortality. So that's how large it is. Let me be very clear. We keep on talking of India as a big economic power. But when you look at rates per thousand, India keeps on trumping nowadays. Whenever you open the newspaper or look at the comparisons which are being made, they say Indian mortality is the least, is so low compared to the West. Why are you comparing with the West? Please compare COVID mortality of India with Bangladesh. It's a poor country. India with Pakistan. India with Sri Lanka. We are the worst. As far as COVID mortality is concerned, we are the worst, almost the worst in Asia. If you look at even acute respiratory infections, we are not doing well. Among most diseases, we are not doing well compared to our neighbors. Our neighbors, especially Bangladesh, before Bangladesh, Sri Lanka, are doing very well as far as healthcare is concerned. Sri Lanka is a model for healthcare, and we must try and emulate them. So, incidence in the developed countries is just about 3 to 4%, while incidence in developing countries is 20 to 30%. So, deaths due to pneumonia in under 5s in the developed countries 1 to 3%, developing countries 20 to 30%. So basically what we have to look at is the morbidity and mortality which is high among children, and especially among below 2 months old or 2 months to 5 years. So this is a very, very important thing. The extremes of age, whether it is small children, babies and small children, as well as the old and debilitated. These are the ones who have problems. Also, the immunosuppressed people always will have problems in all diseases. So if you really look at it, acute respiratory infections is the leading cause of mortality and morbidity in the under 5 age group. Pneumonia as well as this. Okay. Oh, these are some of the statistics. 13% of inpatients death in pediatrics ward due to ARI, 30 to 60% medical consultation, 20-40% of hospital admissions or under 5s is due to pneumonia. And is also the main reasons for drug prescription in children. Unnecessary, potential, dangerous resistance takes place because of unnecessary use of drugs. Okay. The majority of cases of pneumonia in children with high mortality rate is due to Streptococcus pneumonia and Haemophilus influenzae. Haemophilus influenzae does not cause influenza. Please remember this. Commonly asked in the Viva, what does Haemophilus influenza cause? It doesn't cause influenza. It causes pneumonia. Otherwise, it may cause meningitis, various other things which there. It does not cause influenza. Okay, and these can be effectively treated by inexpensive antibiotics which are administered at home, which is being done in our country. We have given antibiotics to the ASHA workers and to the ANMs so that we can possibly treat these things right at home. So I will not go into all these details about the things because this is a revision lecture. So what are the agents? We can see various types of bacteria, viruses and others. And this is the list which we have: Streptococcus pneumonia, Legionella pneumonia, Klebsiella pneumonia, Staphylococcus pyogenes, Staphylococcus Haemophilus influenza, Bordetella pertussis, Corynebacterium diphtheria. And viruses, we have rhino, corona, adeno, respiratory syncytial, parainfluenza viruses. So all these can cause respiratory infections. Also, you can add influenza A and B, enteroviruses, measles, chlamydia, coxiella, mycoplasma. So all these can cause respiratory infections. And let us consider what are the factors which are involved. As I told you, the extremes of age. The extremes of age are the problem. In general, young children and the elderly are the ones who suffer from the problems. Boys are more affected than girls in the younger age group. Adult women are sometimes found to have more of infection, basically because they get it from their children. The children get infected, and then from them, the women get infected. Peak is always in winters. Why is the peak in winters? Basically because of overcrowding. You tend to remain indoors. You try to close your doors and windows. You go in a vehicle with one person who is suffering from ARI, and you have the windows closed. You can possibly suffer from the same infection which is circulating inside. Remember, even in summer, when you have a person suffering from a cold or suffering from a respiratory infection, and you put the AC on, and you put the AC in internal circulation, you are likely to suffer. That is exactly what is happening with COVID. People who were traveling in vehicles it was found that these were the people who were suffering from people traveling in vehicles, people traveling in buses, people traveling in flights. The transmission of virus was very high in these conditions. So attack rates are high in schools or institutions where people congregate, and we have the age mortality is more amongst infants. Half the deaths of children below 5 years or less than 6 months of age is maximum deaths which are there. Income. As the standard of living goes down, the nutrition goes down, the immunity goes down. Immunity goes down, there is more of infection. Parental education, also when you have low education levels, the mother is not aware of how to prevent respiratory infections. Places of residence, again, people who are living in crowded environments, people who are having kacha houses which become moist, they are more likely to suffer from. Smoke. Smoke is another very great problem which is there, and smoke not only from chulas in the house. We are talking about atmospheric pollution. Why was it that we had a problem in Delhi? Recently, we had a problem in Delhi with COVID. The reason was it was combined along with pollution. The burning of the produce of which was there, the farms, in the farms, that burning in the states of Punjab and Haryana resulted in a high amount of pollution which is there in Delhi. And once the pollution levels increased with Diwali coming on, the add-on effect, that's the reason why we had a huge amount of cases which were going down in Delhi. So now that the pollution levels are becoming a little better, you find that the prognosis of the cases is improving. So passive cigarette smoking, also all these things will add on. Overcrowding, cold, humidity. See, how does cold and humidity, cold result in problem? Cold results in problem because the immune system of the body gets depressed with cold. And that is the reason why we have a larger amount of cases which is there. Low birth weight, of course. Whenever you have low birth weight, you have the immune system is not developed fully. And once the immune system is not developed fully, you have all sorts of infections which the child might get. Malnutrition, as I said, malnutrition means decreased protein. Decreased protein means decreased immunity. So you have the problem. Lack of breastfeeding. Breastfeeding, you see, breast milk has got immunoglobulins. Very important that mothers feed their children so that we can transmit the immunity to children. Deficiency of vitamin A is also one of the things which can, deficiency of micronutrients. The behavioral factors, the pattern, how the child is, whether they stay in, whether they are exposed to more risk factors due to the behavioral factors which are there. So transmission is by airborne route, simple, plain and simple airborne route, person to person transmission. And that can be cut down if you manage to spread out the people, no overcrowding, etc. Keep a mask. Okay. Now, well, we talked about this common upper respiratory infection and lower respiratory infections. Let's run through various infections. Common cold. Now, common cold is infected virus transported to the adenoid area where they bind to intercellular adhesion molecules. And you've learned all this in your microbiology. Clinical symptoms occur within 10 to 12 hours. So very different from flu, which has a longer incubation period. Common cold, within 10 to 12 hours, you will find that incubation has been done, and you come from a trip in a car, and by evening, you already suffered from the common cold. Sore throat, profuse rhinorrhea, watering of eyes, nasal congestion, sneezing, cough. Complications can be because of superadded infection. You have middle ear infections and sinusitis. Pharyngitis can also take place in pharyngitis. It can be either a bacteria or a virus. You can have sore throat, fever, headache, swollen lymph nodes, running nose, dysphagia, and dyspnea. Epiglottitis, you have again inflammation of epiglottis or its associated conditions which are there. You can have dysphagia, fever, mild cough, stridor, muffled voice. Again, superadded infection, you can land up with otitis media adenitis, or with the same infection, you can land up with otitis media adenitis, cervical necrotizing fasciitis. It's dicey to get laryngotracheitis, which is also commonly known as croup. As the infection extends to the proximal trachea, diffuse inflammation of the subglottic area causes narrowing of the airway. This is very dangerous and should be considered an emergency. A small amount of exudate in this region can cause significant airway obstruction. So airflow in this area, subglottic region, causes stridor, and it's, as I said, is an emergency. So you can have brassy ceiling, barking cough, low-grade fever, and stridor. So the complication is respiratory failure and death. Bronchitis, the viruses and bacteria causing inflammation of the respiratory passages, which result in irritation. So this bronchitis is very classical. You have a classical cough, and because the bronchus is involved, you have the problem is basically of you have a inspiratory sound as well as an expiratory sound which comes in. So the person suffer from, if you put your stethoscope there, you will find rhonchi over there. There is an increased production of mucus. Swelling of the mucous membrane of the bronchi along with production makes the airways narrow, leading to a wheeze, and when you put a stethoscope, you have rhonchi. Persistent cough, sputum, burning pains, wheezing, painful and difficult breathing, malaise and low-grade fever, insomnia. Now, when we're talking about cor pulmonale, we are talking about chronic obstructive pulmonary disease, chronic bronchitis, not acute bronchitis, chronic bronchitis. So, chronic bronchitis can result in emphysema, it can result in cor pulmonale. Pneumonia can occur from acute bronchitis also. Pulmonary hypertension also is a complication of chronic bronchitis. Bronchiolitis, that the bronchioles are involved, is similar to bronchitis. Only thing is that it involves the bronchioles. So obstruction of the bronchiole from inflammation, edema, and debris. Hyperinflammation and atelectasis can take place, and there's excessive mucus production which is there. Pneumonia per se can be anatomically divided into lobar, bronchogenic, or interstitial, or microbiologically you can divide into bacterial, viral, fungal, and parasitic. And you have, otherwise, if you want to do the clinical this thing, you can say community acquired or hospital acquired. Hospital acquired is also a big problem because you come to the hospital for one disease and land up with hospital acquired pneumonia. I will not go into viral pathogenesis and these things. I've already taught you when we were taking the normal classes. These are all revisions. So gross lung specimens of pneumonia, hospital acquired. So whether there is hospital acquired or community acquired, most of the symptoms are similar. Okay. Grading of the illness in community acquired pneumonia is child age 2 months to 5 years. You have got the 4 grades: very severe pneumonia, pneumonia, or no pneumonia. You have studied all this when we would cover this in detail. When we were talking about integrated child development, or so when do we say that the child has very severe pneumonia? When he's unable to drink, has convulsions, abnormally sleepy, stridor in a calm child, or severe malnutrition. And the features which you are looking for is chest indrawing, fast breathing, nasal flaring, grunting, or cyanosis. Pneumonia which is not so severe has only got fast breathing, that is a respiratory rate less than 50 per minute. Anything above 50 per minute should be put in the category of severe pneumonia. 50 per minute when you're talking about 2 to 12 months, and about 12 months greater than 40 per minute should be put as severe pneumonia. And the other category which will be there is no pneumonia, cough or cold. Okay. The complications of pneumonia are respiratory and circulatory failure, pleural effusion, empyema, pneumothorax, and abscess. What is the treatment? Treatment basically depends on what you have observed. So it's very important that history taking is done properly. the age of the child, a child or adult, duration of symptoms, food and water intake, activity of the child, convulsions if any, very important, and altered respiratory habits, that is irregular breathing, abnormal sounds if you have stridor or something, inability to breathe, and cyanosis if present. Clinical examination, again, you have to decide whether the child has got respiratory rate of greater than 60, 40, 50, 60 is what we put this thing as. 40, 50, 60 is for various age groups. If it is less than 2 months, we're looking at 60 per minute, 2 months to 1 year, 50 per minute, and 1 to 5 years, 40 per minute. Chest drawings, we're looking for stridor, wheeze, whether the child is excessively sleepy. The moment the child is excessively sleepy, we are aware that there is increased carbon dioxide levels. So we have to look at what's going on. The oxygenation is poor at the present moment with partial pressure. You have to look for the oxygen levels which are there. So temperature, signs of malnutrition, cyanosis. In very severe pneumonia, you must admit the patient to hospital, give the patients respiratory support, intensive monitoring is done, antibiotic therapy, treat the fever, and also look whether the fever is due to malaria. Rule that out. The antibiotic therapy which is recommended is chloramphenicol, which is given in case of improvement. Oral chloramphenicol can be given. If the symptoms worsen, you can think of gentamicin or fluoxetine. In severe pneumonia, you again admit to hospital, give respiratory support, antibiotic therapy, treat fever, treat wheezing, and monitor their food and water intake. The antibiotic of choice is benzyl penicillin or ampicillin, and chloramphenicol being kept as a reserve. So in other cases of pneumonia, we would like to do home care, which is advised to the patient. Mother has to be advised with regards to monitoring of the child for symptoms, antibiotic therapy, and treat for fever. And the drugs which have been commonly recommended is cotrimoxazole, sulfamethoxazole with trimethoprim, and this is available with the ASHAs. They give this medicines which are there, 2 to 12 months, 2 tablets per day, or 1 spoon twice a day. 1 to 5 years, they give 3 tablets per day, 100 milligrams of sulfamethoxazole and 20 milligrams of trimethoprim. So if improvement is seen, you continue the antibiotic. If it is condition worsens, the patient is sent to the PHC, and then further the change of antibiotic is done. Now, acute upper respiratory infections, it is if there is no pneumonia, no antibiotic is required. Unnecessary treatment with antibiotics results in development of resistance. Oh well, today, with COVID being present, we have to be a little bit more careful. Whenever a person is suffering from a sore throat, it is advisable to get a COVID test done, RT-PCR test done. And once the person is found positive, then we have to possibly put the person on antibiotics, either putting the person on doxycycline or any other antibiotic, azithromycin or something, which is recommended, and plus doing a follow-up of the patient, giving immune boosters and doing a symptomatic treatment. If the person worsens, you have to ensure that he is taken to hospital. Treatment of under 2 months of children, pneumonia in them is always considered to be severe, is to be treated appropriately and should be hospitalized. Please remember this thumb rule. Any child who is less than 2 months of age you consider it as a pneumonia and admit the patient. Breastfeeding should be continued and antibiotics should be started immediately. So I've already said cotrimoxazole, benzyl penicillin, and ampicillin are the drugs of choice which we like to give. Also, gentamicin is now considered one of the drugs which is in cases where the patient is not responding, you would like to give gentamicin. There is a trial on to give gentamicin to ASHA workers, and this is being tried out in various districts. Chloramphenicol is not advised. It's not advised. The overuse of antibiotics cannot be overemphasized. Overuse of antibiotics become a big problem. Most of the antibiotics which are prescribed are unnecessary, and this has resulted in a lot of resistance. Viral acute respiratory infections are very, very common. So giving antibiotic for them is no use. Poorly controlled use is associated with increased resistance, as I said. Studies show that up to 70% of pneumococci are resistant to penicillin. That's extremely sad. Rational prescription use of antibiotics should be introduced into public-private healthcare systems. Okay, I don't think we need to go through this. Home care. During illness, home care is what is required and must ensure that breastfeeding continues regularly. You must ensure that the child is fed, and breast milk is very good because it has got a lot of immunoglobulins. If he is greater than 6 months old, given nutrient-rich and energy-rich foods like cereals, vegetables, beans, meat, fish, milk, egg, vegetable oil. Child should not be forced to eat. Should eat as much as he wants to. If the child is not eating, please check whether the child has got a blocked nose. Clear the nose. That's very important. Home care is very important for a child, and just I've already covered this. Okay. After the illness, it's required that the catch-up growth is very important. The child would have become weak, would not be eaten during the illness, and so after the child has become better, you must ensure one extra meal is given to the child so that they can regain his weight. Enough fluid should be given to the child, and this can consist of water, milk, fresh fruit juices, rice water, anything which is there. Other measures which are there are improved living conditions, better nutrition, improved ventilation, better mother and child care, and vaccinations. The vaccinations which we do are measles and H influenza. These are both given routinely. In Telangana, we are giving pentavalent vaccine, which has got H influenza. But the other ones which are recommended by various people are pneumococci and influenza, which are not in our normal schedule. Please remember, though this slide said so, we do not give these two vaccines, pneumococci and influenza, to our children in India. And of course, we must ensure a lot of training is given to the community level workers to detect pneumonia and to ensure that we treat them well. That's all from my side. Very short acute respiratory infection revision lecture. We'll continue your revision lectures till we finish. I'm told that most of the revision has been completed and you're all ready for the exams. Ready and raring to go. So be assured that the moment the university decides to have you all coming in, we will have your internal assessment exam. So please get ready for your internal assessment exams. We will ensure that you have your internal assessment exams, and we will ensure also that whoever does not write well in the internal assessment exams is kept back, because when we expect that you would be studying in your homes. If you're not studying in your homes, then you might as well be kept back for another year. So kindly ensure that you study well, revise your topics based and have knowledge which can be used in the exams. Okay. We will, once you come back, we will ensure that we give you the clinical knowledge. Though we do not have enough patients in the hospital, we have developed a dummy case sheets which we will run through the various types of cases which could come in your exam. You have a very unique year which has passed by, and so we have to also change our teaching methodology based on that. Okay, all the best and hope to see you all soon. Where is the cursor?